the coronavirus has been an interesting thing because we are literally innovating on a daily basis,
Mm.
um, often in small ways. So big things like, how do we change an emergency department that is set up and we're handling roughly 120, 130,000 patient visits a year, to one that's seeing maybe 40% fewer patients.
Hi, I'm Dr. Weibo. Welcome to the Innovation in Medicine podcast. As an engineer and physician, I've always been interested in innovation in medical technology. In this podcast, I'll talk to doctors, engineers, scientists, and other leaders in medicine to gain their perspectives on the past, present, and future of innovation in medicine. Today, I'm very excited to be speaking with one of my mentors, Dr. Dr Ackerman. He's an emergency medicine physician at Emory University and Grady Memorial Hospital. He has been in the front lines fighting the coronavirus pandemic recently. With a PhD in biomedical engineering, Dr. Ackerman is very passionate about innovating within the healthcare field. In this part one of our discussion, we explore the role of innovation in the field of emergency medicine and how the current pandemic has influenced new innovative ideas in the way we treat patients. So here is my conversation with Dr. Ackerman. All right, so Dr. Ackerman, thank you so much for joining me today. It's a pleasure to have you in this podcast today. And so just to start, I had an opportunity to meet Dr. Ackerman in undergrad at Georgia Tech as a junior. And I remember taking one of his classes that he was teaching there. And pretty much in that class, we went to class and had an opportunity to go to Grady and Emory to just learn a little bit more about the processes in the ED and how things are going. But at the same time, we were trying to come up and identify different problems that are going on in the ED. So, through that, to be honest, that's one of the things that I really enjoyed, actually. I would say it's one of my favorite classes at Georgia Tech. And so I'm so glad that he, studied that class. And until today, when I'm either in my rotations or whatever I'm in, I always have that vision of, what are the problems in this process? What are the problems in different areas? And so, one of the reasons why I wanted to have him in this podcast is because I really think he's one of those people who have just innovated, maybe the way he taught student, the way he saw different problems in the ED, the way he, just like this class, I think that was really innovative. So I just wanted to have him here to get his perspective on what he thinks about innovation. So Dr. Ackerman, again, thank you so much. And, welcome.
It's great to be here chatting with you. And, it's kind of neat when you get to catch up with a student more than a few years later and kind of see where they're headed.
Appreciate that. So just to get started, I wanted to give you an opportunity to kind of introduce yourself, and just tell us a little bit more who you are and what your credentials are.
Okay. So, as you mentioned, I'm an emergency physician. I went to medical school at the University of North Carolina in Chapel Hill. I actually did a PhD while there in biomedical engineering. Actually, at the time, it was using augmented reality to assist laparoscopic surgery. And I actually was pretty sure I wanted to be a surgeon until one day a surgeon pulled me aside and kind of said, you developed a surgical instrument basically as a medical student. You don't really have to be a surgeon to do this kind of innovation. And in fact, what you bring to it is sort of the ability to look at and identify what the problems are and understand our problems. And you don't have to be a surgeon to do that. You should really think about emergency medicine because they do a little bit of everything. And I thought about it, and that was the direction I ended up wanting to go. So I did residency at Stony Brook University, was chief resident there for medical education, which was great. It put me in a position of really working closely with medical students, teaching courses for them, uh, designed to help them get interested in emergency medicine, understand what we do, and hopefully give them a little bit of a leg up in residency applications. And then from there, I've been down here in Atlanta with Emory and Grady now for, I think we're about 13 years now.
Wow.
And I've also been teaching over at Georgia Tech, teaching classes that are fundamentally about how, as an engineer, to think about working within healthcare and doing innovation within healthcare, which has its own unique challenges if you're not kind of part of this culture that is healthcare delivery.
Yeah, yeah. Thanks for that. And so the first question that I always like to ask everyone who I'm interviewing is, what's your definition of innovation, and to be specific, what's innovation in medicine? Really?
I always struggle to define innovation. A lot of what we do and what needs to happen in terms of innovating is often more of an evolution, sort of this constant search for doing things better.
Mm,
Um, and I think at one time I probably would have given a definition that was much more device centered. Increasingly, and you probably remember from the class,
mhm,
I really want people to figure out what the problem is first and foremost, and then identify the best solution for that problem, rather than specifically worrying about whether we're innovating in devices or something else.
mm.
Um, so I think I'm going to be a little bit of evasive and kind of leave it at that very vague and general. Innovation is about finding new ways to do medicine better.
Yeah, yeah. I mean, I think actually you mentioned that that's one of the things that I really got from that class. I think coming in initially, I was more of a, you know, what's the coolest thing right now? And let's do that instead of actually finding out what the problem is. Because you have to find out who's, I think you remember talking about this, who's my user, who's going to be like that person using this thing, who's there. Let's look at, is it a nurse? Is it a doctor? And where is the problem here? And let's solve it instead of just going out there and putting stuff which might actually end up hindering that
Yeah.
process. So I completely agree with that. And so, can you tell us a little bit more about maybe the history of maybe a little bit of emergency medicine, the present, and where it's going, and then how can you tie that to how technology and innovation has improved your field overall?
So, I think a lot of medical specialties really exemplify kind of how I think about innovation, and certainly emergency medicine is sort of a prime example. Emergency medicine, in terms of medical specialties, is actually a relatively new specialty. So, if you go back to the 70s, the early 70s, in the United States and internationally, emergency medicine didn't really exist. And lots of reasons why that was. Part of that was that there was not any recognition of a need for infrastructure to support it. Part of it is, unfortunately, at the time, medicine was, relatively speaking, simple, in that you could have a general practitioner who could do most of what was possible to do in medicine.
Mm,
And then you would have some specialists, and certainly surgery was already breaking from that, where it was pretty well recognized that, the people who cut and did those sorts of interventions were maybe a little bit different from, say, a general practitioner. And a couple of things happened at once in the 70s. We started having a lot more medical knowledge, a lot more devices, a lot more specialized procedures. And so specialties that already existed really kind of flourished. They really started having many more interventions, new tools to do new procedures. Antibiotics were well established, so post-operative infection rates were going way down.
mm,
Um, and we started having science to measure new things about the human body. to where even within internal medicine, there were more and new specialties that actually had stuff that they could do, and much, much more specialized knowledge than I think we'd ever really seen before. Um, we had some recognition that things like deaths from injuries required specific and timely interventions that not everybody was really set up to do. And so that led to the rise of emergency departments rather than emergency rooms. And so the model of emergency medicine really had been somebody's hurt, you send the vehicle out and pick them up, which in many communities was literally a hearse because it was a vehicle set up to move a body. And if they were alive when you got to the hospital, there was a room where somebody would look at them before putting them into a hospital room. And that fairly quickly evolved into there being some algorithms and some things that you would do in a more timely fashion. And that's really where emergency medicine developed. For a long time, the logo for the American College of Emergency Physicians was this box with a whole bunch of squares in it, and one square was Michelin. And basically, each of the squares represented the established medical specialties at the time, and the missing square was emergency medicine because it wasn't recognized as a specialty. Um, and the residency programs and the training programs were rapidly establishing that folks that were specifically trained for doing that initial evaluation, treatment, stabilization, had better outcomes, better longevity in the job. And that's really where the specialty of emergency medicine came about from. So you can kind of see that it was a innovation of itself, that realization that there actually is a specialized domain of knowledge that's needed to take care of people and do that early assessment and treatment. And the specialty continues to evolve, continues to define itself. There are areas like observational medicine, which is essentially an invention of emergency medicine that really comes about in part because of some holes in billing issues about how the inpatient team gets paid versus outpatient doctors, and that increasingly insurance companies and CMS don't want to pay for kind of shorter term inpatient hospitalizations that you might not have appropriate diagnostic codes for. But there's this sweet spot where it can be an outpatient observation and then in emergency medicine, because we've done much of the work to meet all those billing requirements, we can use those codes, and that lets us much more efficiently deliver care for patients and hopefully keep costs down as well.
Wow, nice. It's amazing to see actually that is, as you said, it's an innovation by itself. Like literally seeing we have a problem here. We have all these people coming down, and then now there's a gap, and there you are. So that's amazing. But the next thing I wanted to ask you was that what kind of I guess day-to-day things are you using in terms of like innovative things you think you're using actually in your perspective in your field?
Um, so a lot of what I see as being most innovative that I use day to day actually are some of these processes and approaches
Mm,
rather than devices specifically. Many of the devices that we get are sort of hand-me-downs from other specialties. Uh, and here and there, we will have devices that are kind of our own. Um, but, you know, even if you look at things that I guess a lot of healthcare as a whole sort of owns, things like the ACLS algorithms, um, you know, that those are algorithms that are reviewed and modified and have this cycle that they go through. And you know, I've now been in this long enough that I've seen, I think I'm up to 5 or 6 revisions of ACLS.
oh,
And although each change has not been huge. I mean, fundamentally, we're doing chest compressions and early shock and all of that.
Mhm.
There have been pieces that have come and gone. There are pieces we used to think were important that now we're fairly confident are less important. Um, watching people who are still struggling with remembering that the algorithm is not ABC anymore
Mhm.
uh, is sort of an amazing thing to see. And it's something that many of us in emergency medicine, that's what we do every day. There are pieces in our interface with other specialties. So how we handle STEMIs, so the ST elevated myocardial infarctions, and the rapidly evolving literature about what EKG findings
Mhm.
are the ones that I actually need to call the cardiologist in for, um, has been somewhat remarkable. Trying to keep up with the literature about which patients' interventions are actually useful
Mhm.
beyond just the EKG changes are things that, certainly it's not necessarily exactly what I do. I'm calling the cardiologist because I know it might be in a range where that intervention might be more helpful. But I get to hear from the cardiologist, oh, there's a paper last week, and because there's no EKG changes in V4, this isn't a patient who's likely to have any change in outcome by cath lab intervention. Um,
Mhm.
so we get to see a lot of these things in other areas. Um, you know, the coronavirus has been an interesting thing because we are literally innovating on a daily basis,
Mhm.
um, often in small ways. So big things like how do we change an emergency department that is set up and we're handling roughly 120, 130,000 patient visits a year to one that's seeing maybe 40% fewer patients,
Mhm.
except a substantial number of those patients either have or potentially have a highly contagious virus,
Yeah.
right? And so that, you know, watching what the numbers of patients are, looking at square footage, room availability, having somebody figure out what the ventilation rates in different rooms are,
Mhm.
um, dynamically changing what interventions we do, teaching ourselves, our residents, our nurses, yes, I know the patient is going into cardiac arrest, but you have to put all your gear on first.
Yeah.
And yes, I know we're about to run a code, but with everybody wearing gear, we can only have 4 people in that room. We
Mhm.
need to make sure that we're keeping enough PPE in reserve, that we're using the resources in the room efficiently, that we're minimizing our exposure of staff. Um, and so in this week, that's unfortunately probably where we're innovating the most quickly.
Mhm.
Rolling with the punches as we run out of one type of gown and have to figure out how to practically use a new gown that maybe wasn't even intended for use in healthcare in the first place.
Yeah.
Um, watching everybody figure out how to not get the sores across our noses from wearing the masks all the time.
That's actually.
Um, Lots of bits and pieces that it's becoming a real-time process, some of which is going smoothly and some of which unfortunately does not.
Mhm.
And there are times where we can go through a more formal innovation process and really sit there and stop and think, okay, what's the problem and what
Mhm.
resources, and do a full analysis. And other times where we really have to do a lot more just jumping in and realizing we are working with a solution that realistically we should all know is less than optimal,
Mhm.
and try to correct it as we go.
Yeah. Yeah. That's funny that you mentioned the sores because I was just volunteering giving out food the other day, and I was wearing that mask all day, and I just developed that sore, and I was like, that's very interesting. I can't imagine the people who have to go in every day and wear this thing. So it's definitely tough. But you mentioned something actually that that's interesting to me, because I know that when it comes to especially medicine and healthcare overall, and you're trying to maybe make a new device or create something new to be integrated in the healthcare field, that's usually a challenge. And so I just kind of wanted to get a little bit of your thoughts on that, and how this COVID crisis has maybe will help us change some of those things, right? Because when you're creating a medical device, for example, it takes years and years for you to actually get it into market, right? Or if you're creating something that to go into healthcare, that's usually the process is really long, as you mentioned. How is this going to change that? Do you think this might help open some minds out there in how we're reviewing things, and maybe speed some things up a little bit?
Um, so I think we're gonna see a little bit of a wave of some new devices.
Mm,
I sort of hope that many of them will have to go through kind of the longer development process, because there is some value in doing that rigorous testing and all of that
mm,
that conventionally has been part of our approval processes. Um, the best thing for spurring innovation is having a problem.
yeah.
And obviously, having a large portion of a population getting sick, with a large number of people getting really sick, with putting other people in the community as well as healthcare providers at risk and taking care of them, it's suddenly obvious that we've got a problem.
Mm-hmm.
Um, Now, as you recall, defining what the problem is in a way that we actually might have some chance of coming up with useful solutions is problematic. Um, the cool thing is that there are a lot of areas that are specific causes for concern. So for us in the emergency department, since airway management is a big thing that we do, and intubating people and helping with respiratory issues um, is particularly problematic in high risk or with patients with COVID.
Mm-hmm.
um, this is spurring a lot of thinking about how we can do airway management differently. Um, and I'm a little hesitant, as you heard, to use the word differently, because fundamentally we're managing it the same way we always had. We're going to shove a tube down that throat, right?
Mm, yeah.
And until somebody comes up with something different, which doesn't seem likely, but good challenge.
Mm-hmm.
Right. The issue becomes, okay, how can we, the problem is that the process of putting a tube down somebody's throat creates a lot of aerosols and exposes everybody to higher risk. So we've seen a whole wave of different thinking about, okay, I'm already wearing my mask, I'm already wearing my safety goggles. How can I protect myself a little bit better? Is there additional gear that I should be wearing? Can we do things? And so there are any number of different approaches of these plexiglass boxes that you put over the patient's head,
Mm,
um, and other things to sort of contain the aerosol production. There have been a number of different suggestions about how to do the procedure in ways where you decrease the likelihood of generating aerosols. If you watch what our respiratory therapists are doing, there's increasing awareness that the circuits, the respiratory circuits that they're using and using a BVM, are risk points, and that how you connect and disconnect the patient from the circuit when and how we use a BVM
mm,
can be modified and decrease the risk of creating aerosols. So we're seeing this rapid flurry of ideas, some of which seem to be great. I look at them and go, great idea. That's awesome. I'm going
mm,
to do that. Others I look at and go, oh, I see why they thought of that, but um, that's not going to work so well. So
mm.
I already specifically mentioned the plexiglass box.
Yeah.
You can probably find some pictures of it, but basically it's a plexiglass box with a couple holes in it for us to
Mm,
stick our arms into. And the idea is to have the patient's head in a fully enclosed chamber, so any aerosols generated in there are very unlikely to get spread around the room.
Mm.
I don't like the box. What I actually have been doing when I've been intubating is something a little bit simpler
Mm.
that works better for me, which is basically I put a thick, clear plastic sheet over the patient's head,
Mm.
right? And part of that is with the plastic box, I feel like where I can put my hands is too constrained.
Yeah.
And I don't have much ability to reposition the patient, to reposition me, to get at the patient at different angles. Whereas that plastic sheet, um, it makes it a little harder to see what I'm doing. It's not quite as clear a view, but it gives me much more flexibility. Um, which sort of points out one of the other things that we run into when something is ripe for innovation is there will be competing approaches,
Hmm.
and you know, the market will figure it out.
Yeah.
We'll get there eventually. um
I,
yeah.
I,
So,
I think that makes sense, right? And the fact that you guys kind of just had to develop something to help with that problem, and nobody really had a chance to like maybe test our device, quote unquote, with different users and different people. Like now you're finding out, oh, that's not that great for my hands. And I don't know how many people used it, but I'm sure everybody has their own.
yeah, and it's interesting you mentioned, sort of lack of testing. This is something that, as I understand it, there've been a couple different people who've come up with variations on the plexiglass box.
Mm.
Some of whom I've seen pictures and videos of going to the sim center and running a lot of different providers through
Mm.
using it and getting feedback and doing a little bit of an iterative cycle on it.
Mm.
um and have I used it? I tried to use one version of this plexiglass thing once and discarded it very quickly. Maybe I had one, a version that hadn't been properly tested. They put the holes in the wrong place.
Mm.
Maybe this is a me problem and not a universal problem.
Mm.
Um, it was something I can tell you in the heat of the moment. It was not something that I wanted to play with when I needed a patient to be intubated now. Um, the fact that I know a lot of people who absolutely love those boxes suggests maybe at some point when I get a minute and we can get around some of the social distancing issues, I might be willing to go to the sim center and try it out and figure
Mm.
out how to make it work for me.
Yeah.
Um, but that's part of the challenge of doing a lot of new things all at once is, there are going to be some people who are not going to like whatever the new thing is, and maybe I'm right about the box and it's not really all that.
Mm.
And maybe 3 months from now I'm gonna be like, yeah, I don't know why I didn't see it from the outset, this thing is awesome.